Okay, so today we will start with our case presentation. This is a 18-year-old female patient. نبلش بيمن. يلا جماعة الدوبلر أول شيء. منو الدوبلر؟ يلا سهلة. Suki. 18-year-old female patient presented with abnormal pelvic ultrasound. MRI was requested. So, what do you see? Tell me what you are thinking. 18, 1-8. And it's straightforward, yani don't overthink it. First of all, MRI, sagittal view, T2 weighted images of a young female patient. Don't judge just by looking at one sequence. You have a lot of sequences. See more than one to avoid any surprises. هذا T2. دقيقة لحظة. Leave the mouse. هسه هذا شنو هذا fat suppression. T2 fat sat. So it's suppressed on T2. عافية. زين انتي ما تشوفين الاكزيال كورونال This is what T2 weighted coronal showing. Describe.
Showing rounded lesion at the right ovary.
Simple, complex. Homogeneous but septated, multiloculated. There is another locule here, so it's a multiloculated lesion. This lesion appears at T1 شلون or at T2 شلون? How does it look on T1 and on T2? انتي وشفتي ال T1? Where is T1? ما شفنا T1. كان T2. اي الحمد لله. انزلي بعد. اي. So on T2 it is what?
T1
hyperintense. And on T2 less hyperintense. Hyperintense but less. And it is suppressing on fat sat. So all the findings points to fat containing lesion. So fat containing lesion in an ovary, it's most likely will be a dermoid cyst. Exactly. So this was a dermoid cyst if we give contrast, what do you think will happen? Will enhance or will not enhance? It will enhance, but will be faint and mostly peripheral in the wall. Okay? And in order to see the enhancement, you need to do what? إذا حتشوفي الانهانسمنت شو لازم تسوين؟ لازم تسوين T1 fat saturated. ليش fat saturated؟ لأنه هو hyperintense on T1. How you will see enhancement in something that's already hyperintense? You need to suppress the fat in order to see is there enhancement or not. Sorry?
If there is enhancement.
Okay.
How we can differentiate it from infected dermoid?
هنا يدخل عندك أول شيء الكلينيكال. أولا يدخل عندنا الكلينيكال. Is there any features of infection or not? Second, infected will be associated with some surrounding of the surrounding vital planes, some free fluid, things like that, possibly lymph nodes. So this will be more in favor of infected or complicated, let's say. طبعا إذا كان عندنا lymph nodes و free fluid وكذا, we will have the addition of possible immature teratoma. You should keep it in mind, which is malignant teratoma. Sorry? Yeah, on the fast saturation it's hypointense. Well, should be, not always, not مو شرط إلا, not 100%, but if you see solid component more, irregularity more, heterogeneity more, of course other lesions, this is more in favor of immature cystic teratoma. Okay, good job. زين, يلا جينا. Since today I don't have my الداتا sheet, I don't know what case is what, فخلينا نسويها حظ يا نصيب. Choose your poison. دقيقة لا تسوي, العب الماوس, اتركي الماوس. اختاري من 1 إلى 220. لا تختار, أوفي الماوس. جنان, تركي الماوس, اختاري رقم.
يلا اختاريت.
شو اختاريتي؟
طلعنا رقم 2.
رقم 2.
7 راح 7.
يلا 7. I have no idea what's the case, so absolutely no idea what's the case, so you have to figure it out. هلا, يلا go. This is a CT scan of a female patient of chest. هاي أول شفصة. هذا الكورونا والساجيتال الموجود يمك مال شنو هذا؟ مال chest abdomen. So first we start with the axial. We don't start with the corona. See what's going on. With or without contrast? Without contrast. Good. So it's a native CT scan. What do we have here?
We have
كملي الصور كلها, يلا تحكين. لأنه to avoid unpleasant surprises. So say what you are thinking, حتى لو غلط. مهم, don't stay quiet and keeps everyone wondering what's going on. Speak. This is a CT scan, non-enhanced CT scan of the abdomen and pelvis of a young female patient. Axial, sagittal and coronal views showing.
right hydronephrosis.
Okay.
Due to stone at the distal urethra.
Where is the stone? أوفي هذا. راونيها بالأكزيال. قلت لك we start with the axial. Where is the stone? You say there is a hydronephrosis on the right side caused by a stone. Is this a stone? Is there a hydroureter or just hydronephrosis? ها؟ صوت بدأ أسمعك. This is the image that is available.
Just hydronephrosis.
صوتك شو
أنا
تحكي
قلت just hydrophobia.
just hydronephrosis
Yes,
so there is no hydroureter
no hydro.
so can you have a stone without hydroureter just hydronephrosis
Yeah, we can.
Maybe.
اصبري يا ريهان دقيقة
إيه
ممكن
إيه.
زين
ممكن إذا كانت الستون هم ما تبين بالسي تي
مثلا
ريديولوسنت إلى
اذا ريديوليشن ستون يكون ما عندك هydroureter بس hydronephrosis شنو علاقة الدنسيتي مال الستون
يعني hydronephrosis without
زين تعالي للكورونا so all we have now is hydronephrosis how to explain that في دقيقة
يعني نخلي مثلا differential diagnosis
مم.
اللي هو ممكن يكون peripelvic renal cyst أو parapelvic renal cyst
اوكي or
أو هو hydronephrosis.
شباب بليز
هي يا hydronephrosis
من
يا
اللي
يا
هذه خلي
renal pelvis. فنعطي contrast ونشوف.
نعطي كونتراست ونشوف زين اذا قلت لك if I told you لا هيدرو لا بارابلفيك ولا بيريبلفيك ولا سيست اصلا
ما cyst.
and this is a real genuine hydronephrosis what would you say was the cause
ممكن يعني congenital anomaly.
like what what causes hydronephrosis congenitally
ممكن
هسه انت راح تقومين وراها ونشوف شطارتك اوكي
إيه ممكن في يوجي obstruction without بس ال PU إيه pelvic junction obstruction صح.
so
maybe.
مو maybe it's the only cause that will give you hydronephrosis in young patient without stones is congenital neglected pelviureteric junction شنو غلط stenosis
Stenosis.
وليس obstruction not obstruction obstruction will cause complete obstruction it will not reach this age it will be managed much earlier at an infancy but stenosis the kidney is still functioning you have cortical thickness the cortex is still thick
How is
Okay.
it? By age?
first by age second you give contrast you give contrast and see the delayed and you look for a very delayed image like take an image after half an hour very delayed if you see contrast in the ureter then this is stenosis
If we not see it, that's...
if it's not seen then that is obstruction okay and
The
it,
other kidney also, I think... they-
usually when this happens they happen bilaterally maybe into different degrees so there is some dilatation of the other side also some hydronephrosis okay indicating a less severe stenosis at this kidney
And could be extrarenal
extrarenal pelvis it will not be like this big
No, not
the other one yeah it could, طبعا the other one it could but since we have PUJ stenosis on one side think always يعني congenital anomalies happen يعني in collection they don't happen once
Most likely.
well we have to do what to confirm presence of reflux or not
Cystoid.
cystourethropy and the gold standard is what is radionuclide
Yes,
Sister.
that's radiation.
okay not the radiological one the nuclear one
بالنسبه للتروكاوا يجيب هيك شيء تروكاوا
retrocaval
Mega
شنو retrocaval
Because mega ureter. We don't have here mega ureter.
retrocaval هو part of congenital يعني it's a congenital anomaly you have to يعني see it in an early age group okay الميجا ureter when we have vesico-ureteric reflux you will have a large mega ureter which we don't have here
Yeah.
so this is just accidentally diagnosed PUJ stenosis okay يلا بروين
ما يصير أنا الله بخير.
هسه قوم مش تخافي خير من الله 200 كيس قومي يلا ايش بيك يلا راوينا الشطارة. عوفي الماوس، تركي الماوس. leave the mouse. يلا choose your poison.
نمبر 7.
و7 هسه شافتها كل شوية 7. افتوا ال 200 كيس تكلمتوا بال7.
والله ما اعرف.
إذا هو فد رقم مو غلط يعني.
يلا أنا اختار لك. I will choose your poison.
خلاص.
The easiest thing, part 1. Huh? So, what is this exam? وين الشطارة العاد؟
Urethrogram.
This is urethrogram. How do we do this urethrogram? What's the procedure? أنت مو primary?
Yes.
So it's in your job, يعني in your business. Describe the procedure of urethrogram. How do you do it? إجاش للكلينيك دكتور كاوا داز طب مريض يوريثروجرام. شو تقولي له؟ ما أعرف أسويه؟
By putting a catheter.
What kind of catheter?
Follis catheter.
Follis catheter. Where?
Inside urethra.
Inside urethra. To which level inside urethra? In the penile, in the membranous, in the prostatic urethra. Which part of the urethra? What's the size of the Foley catheter that you will use?
According to age.
According to age. هذا عمره 55 years old. What size will you use?
16.
16. نعلتي سلفة زين. اوكي 16 شايفتها ايش كبرها 16؟ حصان ميت 16 هيك يعني هيك كبرها 16. What kind of contrast do you use? Barium or water soluble? Urographin يعني water soluble or barium?
The barium is used in GIV.
ما سألتك what are the uses of barium. What kind of contrast will you use in a urethrogram? Barium or water soluble contrast?
Water soluble.
water soluble. زين. What اللي هو يعني مثل شنو? For example. Okay. So you put the catheter and you push the contrast. How much will you push? على الشطارة بتطلع هنا 300 سي سي تدفعين؟ والله لا أنا أقدر والله لا أرسبش ترسيب. 300 سي سي بيوريثرا ليش صار؟ البلادر نفسها مدفع إلى 300 سي سي.
إذا عندك تروما تعطين.
جنان. اصبر. 15 سي سي. And what do you see here?
You see there is a
تمام.
Yes. There is a gap.
زين. You have 4 images. Why you see only one and you judge? يعني تشوفين بقية الإيمج؟ بالويل.
Here there is a urethral injury.
Describe what's your report will be for this case. What do you see? Tell me what you are seeing.
There is a gap in the or
Discontinuity.
of the urethral mucosa.
Okay. ريهان دقيقة اصبري لي يا ابويا. صبرك عليه. Huh.
At
First of all, what's this? This is bladder.
Yes.
So this contrast coming from the urethra because it's a retrograde urethrogram.
Yes.
First of all, for the urethrogram, you use the smallest possible Foley catheter, regardless of the age. For me, I use size 6 or 8 French, not more, because the urethra is small. It's not a bladder. And you put the urethra in the penile, the catheter in the penile urethra, you get the balloon, you inflate it with air, not with water, because air will give more compliance. It will not rupture the urethra. راح يصير lock بس not rupture. يعني إذا سرنجة تحطها هواء وتسدها تقدر تدفعها، تقدر تسوي هاي بريشر، بس إذا تحط بيها فلويد ما تقدر تدفعها أصلا، راح تطق لليورثرا. اوكي فيو انفليتد with air where you put. بس لحظه ايش بيك بس دقيقه اعطيني مجال شكو يا معوده. You put it where? In the fossa navicularis اللي هي the end of the urethra. There is a dilatation. Okay, you put the balloon in the beginning of the urethra and you inflate it. Usually for me I use not more than 2 to 3 cc of air, and it's very painful. So the more you push, the more painful it will be. Okay, you just put the tip of the Foley, including the balloon. You look for the location of the balloon على الفولي وين صاير. تحط الفولي البالون in the urethra, تشوف البالون دخل باليوريثرا and you inflate حتى شنو يقفل, to lock it. And then before you start, very important point, you fill the catheter with contrast. ليش؟ لأنه إذا تحط الكاثيتر وأنت ما معبيها contrast ايش راح يصير؟ من تدفع راح يفوت air, راح يصير multiple bubbles على شكل filling defect. أنت ما تريد تشوف filling defect. ف you put the syringe filled with contrast, usually from 10 to 30 cc depending on the age and on the size of the, you expect the how much. It doesn't matter, you can put even more, you can put 50 cc and you push as you need, it doesn't matter. Okay, but not less than 10 will be not enough. Even إذا 55 years old, he's a big guy. So you put the syringe in the Foley and you put the Foley in the urethra, you inflate, okay, and then you start pushing contrast and taking images. Especially if you have fluoroscopy unit, you go under direct vision, real time video, okay, to see it. How to do it, okay. When you stop when there is intolerable pain first, or if you see the contrast passing to the bladder, then you have visualized the entire urethra, okay. Or if you have resistance, a lot of resistance, you push and you feel resistance, you stop, because if you push harder you might rupture the urethra, which you don't want to do. Okay, now what do we have here? We have the following. First, this is not a gap, this is a narrowing. A gap means contrast is showing this end and maybe just little bit of this end, and the other, all of the rest will go around the urethra. This is due to rupture. Second, you didn't ask about history. Is there a history of trauma or chronic infection, urethritis, STDs? You didn't ask. When there is history of trauma, then we say this is possibly, if it's acute, we could have like submucosal bleeding, things like that. If it's chronic, then it could be urethral fibrotic process, some fibrosis if it's old, okay. And by the way, this is not the most important finding. There is another very important finding that you didn't even see. What it is?
Here, what it is?
What's this streak, this line? What is it? Is it another urethra or what?
ليك
Guys. صاحبت يعني زميلتكم ده قاعدة. This is contrast tracking outside the urethral lumen,
يس
okay?
Yes.
Suggesting either leak or some kind of a fistula or sinus tract, okay? And of course, in this case, with multiple penile, multifocal narrowings and contrast leak, we have number one differential is what? Rehan?
This is not a drug.
Hey.
It's not here. It's litters or I think or Cooper's gland.
But
They come from membranous and extending to the bulbous. It's normal. Sometimes will be appear on.
it can be
urethra.
also Litter's gland, exactly.
Cooper's gland, I think.
However-
Litters gland is more in the penile part.
How-
while Cooper's gland is extending from membranous to the
How-
bulbous.
However, is it by accident that you have this at the same site of a second narrowing and just
No,
this
it's extending from membranous to the bulbous, but I can see two strictures.
two strictures
It's more interior, it's more in favor of infection. rather
more
than
than if
trauma.
it's
Trauma is
exactly.
more posterior
It won't be a trauma because it's multifocal,
or anterior.
okay, and it's anterior. Well, and it can be trauma also anterior, يعني it happens. The penile urethra إذا pelvic fracture تصير posterior. In cases of pelvic fractures, which we don't have here. So anyway,
حتى التروماتيك instrumentation يعني
على
كمان
على الممبرينس يكون على الممبرينس.
على البوستيريور part.
هو الممبرينس. Okay? Membranous part is the weakest part of the urethra. Weakest, مو narrowest.
Even it's narrow.
The weakest part of the urethra that's always susceptible to medical instrumentation injury is the membranous. Okay? Membranous urethra. So here we have multifocal strictures in a 55-year-old male, طبعا of course male, without history of trauma, suggesting chronic urethral infection causing post-infectious stenosis and fibrosis. Okay? Whether this is a normal gland filling with contrast, if it is a fistulous tract, this is extra finding. However, the most important findings here are multifocal narrowings. Okay? Good.
Okay, how many do you take? I think 4. How many do you will take for this one?
Until I feel satisfied. Sometimes I take 1 and it's enough. Sometimes I take 6 or 7.
Oblique.
Mostly, the most important thing is the oblique. Okay? Very important to have oblique because you'll see the whole urethra in extension. Not bad idea to have an AP view
Beautiful.
to see any side tracks or side, if there is a track or something, you take more view of laterality of the lesion. Where is it extend? Always we need to take in any radiological exam at least 2 orthogonal views.
Sir, you just did retrograde urethrogram.
Yep.
We need dynamic. We should give 250 to 300 cc to see at the first anterior urethra. Then the bladder should be filled. Then after that, voiding.
هذا اللي تحكين عليه.
Anterior, posterior.
What you are describing is retrograde cystourethrogram.
For dynamic.
بس اصبري لي يا اصبري لي خلي اعطيني مجال. Retrograde cystourethrogram, you put the catheter in the bladder and you distend the bladder with 2, 3, 400 cc and then you ask the patient to void and you do the imaging during voiding. This is cystourethrogram. Here, this is urethrogram. Retrograde urethrogram, no cystogram. Urethrogram, if you push 200, the patient will never see your face again.
ما معليش الحالة مرة دايناميك لا تدوم سوية نشوفهم.
إيه.
نعطيهم
Retrograde cystourethrogram. You fill the bladder, you ask the patient to void, the patient voids, and then you take images of the full bladder, and in during voiding, you see the entire urethra during voiding. But the catheter is in the bladder, not in the urethra. in the urethra and you push to 300 cc's, it's يعني it will not finish. You, in order to push like 20 or 30 cc, you need a long of time and patience and calm down, take deep breath, and you know, it's a very يعني delicate procedure. قول يعني.
يعني باخذ مثلا تروما بس الاسندي يعني احنا بس الانتيريور نشوف بس البوستيريور ما نشوفها
اوكي.
لازم نسوي الاسندي
هو هو شوف. When you are suspecting urethral injury, okay, in order to do, you cannot put a Foley catheter in the bladder. You never do it. مهما كان السبب. Because very easily you will convert partial tear to complete tear. راح تقصي لليورثرا وراح يفوت بموال ثاني. Just because you try to insert the Foley. So you put the catheter in the fossa navicularis at the anterior penile urethra, okay?
تقريبا كم سنتيمتر؟
Like 1 or 2 centimeter. Very at the beginning يعني, okay? And you slowly, gently, you push the contrast. You confirm that there is no contrast leaking into the peri-urethral tissues. And then you progress slowly, you push more and more to see as much as possible of the urethra. If the يعني إلى حد membranous urethra, you've seen it, okay, there is no problem, then you can proceed more for entire urethral imaging. Case of infection, you look for a urethritis. These are for multifocal areas of neuromics and stenosis and things like that.
دكتور أوميدي continuous.
Yes, iodine containing contrast. Okay. احنا وقت ما خلصنا مو اكو امتحان بالتسعة عندهم ما الدورة ما ادري شنو فد شي ما الدورة.
أين أخذ كيس؟
يلا منو يجي بعد؟
أجي أنا.
يلا تعال انت. شو اليوم شهيتش مفتوحة؟ يلا بيك نمبر.
أنت اختار.
ما نختار؟ ما اجى جلال اليوم؟ والله مع مشكلته مع الاسف. زين خليها الجلال. لا والله حرامات. يلا خل نشوف. 27-year-old patient I think خمناس وصلوا maybe. لا هذا تركي مو برين. تركي عرفت شنو الكيس. ما يفيدك. خلينا نشوف هاي. ankle. يلا right foot of a 14-year-old female patient. حالي من حالك ما اعرف اي شيء عن الكيس. انا راح اشوفها وياك. يلا قلبي.
أنا الأكل يا دوب بالني شوي أخطأ.
والله بالامتحان يجيبوا لي هيك مش مدري وين انه انكر.
It's showing to the toe the image. So this is a foot, ankle and foot يعني. Okay, if the ankle joint will be mainly focused on the ankle itself, you will not see the tip of the toe. زين. راوينا بعد images. هذا السيرفي عفي. يلا ايه قلبي خلينا نشوف.
شوي صعب يعني. صعب. اشتري هيستوري ماله؟
شو مدري انا هسه شفت الكيس مثلك.
فيميل أو ميل؟
female 14-year-old.
أيوة شو؟
ايوه شنو الهيستوري؟ ويش مدري والله ما ادري. First you should ask for an X-ray. Exactly, good job. Which I don't have.
زين
هذا اليوتيوب ليش شرحت؟
You have to ask.
ليش مقطوعة الصورة؟
شو اسوي؟ التكنيشن مالتي غير. عمك ما يعرف يصور، شو اسوي له؟
عند
Where is the abnormality?
أنا أشوف أكثر يعني swelling في السكند دور
There is abnormal signal intensity seen where?
adjacent to the second tarsal bone.
يعني where adjacent? Dorsal, ventral, medial, lateral. شنو adjacent يعني؟
around the second tarsal bone.
Around the second metatarsal
High signal
bone.
intensity in the second tarsal bone.
اوكي. زين انت ليش ما تروحين للاكزيال ايمجز مو احسن؟ هو نفس السؤال اللي كنت بيه انت؟ يعني اللي هو السكشنال خلينا نقول. اي. نعم. عوفي الماوس عوفي. يلا شوفي هنا. وين الابنورماليتي؟
between the second and third toe.
What's abnormality?
Soft high signal intensity.
High signal intensity edema seen between the heads of the second and third metatarsals at the level of the metatarsophalangeal joint. Palmar or dorsal, or plantar or dorsal, sorry. It's dorsal.
Yes.
On the dorsal aspect, extending into the intermetatarsal space, little bit into the plantar aspect. Yani it's extending from here through the space into the plantar aspect. Okay? What kind of abnormal signal intensity? It is hyperintense on T2 weighted images. So, the important question here, is the bone involved or not?
Not involved.
The bone shows no increased signal intensity, so indicates no bone involvement. What will be our differential diagnosis of such? طبعا extending distally into the toe itself, the second toe is also shows peripheral soft tissue swelling and edema, and also the third toe is showing peripheral soft tissue edema and swelling, and the bone shows normal signal intensity, indicating it is not involved. You can confirm it by looking at T1 weighted images, because T1 is better for anatomy, and you can see the bone is relatively preserved or intact. Okay, let's go to some other views. You can see here it is in the soft tissues infiltrating into the toes here and there. So what can be our differential diagnosis for a case like this? Mortineuroma, exactly. However, mortineuroma usually occurs where? In the plantar or in the dorsal aspect? It's usually in the plantar aspect, and it appears as hyperintense on T2. By the way, mortineuroma is a misnomer. It is not a neuroma. You know that, right? Mortineuroma, it is not a neuroma at all. It is a perineural fibrosis. It's just fibrosis surrounding the nerve. It's a mass on the plantar aspect. Patient walks on it all the time. It causes edema of the surrounding soft tissue. Get it؟ يعني مو لأنه هي fibrosis فلازم تكون هايبو بالعكس هي بالعادة تكون هايبر. يعني تخيلي حباية برجلك ما تمشين عليها شو يصير؟ inflames فتطلع هايبر. Get it؟ It's very, very rare to have a real neuroma in there. The commonest thing is to have mortineuroma. لا لا ما مطي. So, what else other than mortineuroma? What can we have? Depending on the history of the case طبعا. Yeah, she's 14. ما تلحق توصل مرحلة الشاركوت جويد. 14 1 4. trauma,
هيماتوما
infection.
يعني هو
Infection, you mean? Infection and cellulitis and things like that. Preserving the bone, because if the bone involved, then we've gone into مرحلة الأوستيومايلايتس واختلاف المانجمنت 100%. Okay? Thank you very much.
Thank you for it.
See you إذا الله خلانا طيبين. Thank you.